In the summer of 1971, researchers at Stanford University built a fake prison in the basement of the psychology building. They wanted to observe exactly what happens when you give one group of people absolute, unchecked authority over another. The study's architect, Philip Zimbardo, took college students and randomly assigned them to be either guards or prisoners. The prisoners were stripped of their names and given numbers. The guards were given uniforms and batons. Within days, the environment spiraled into severe abuse. The descent followed a predictable psychological sequence. First came de-individualization, where the prisoners were no longer seen as human beings, but as inventory. That paved the way for authoritarian control, where the guards enforced brutal, arbitrary rules simply because they could. Finally, the prisoners sank into learned helplessness, accepting the abuse because fighting back only made the punishment worse. The cruelty didn't happen because the guards were inherently bad people. The abuse was an inevitable feature of the system's design. When you build an environment that strips away identity and removes accountability, human behavior adapts to those rules. Consider the modern clinical environment. It operates under a specific set of rules developed over the last 2 decades. For patients with chronic, complex pain, the architecture of this system dictates how they are seen and how they are treated. Over the last decade, a massive regulatory crackdown on opioids collided with a hypersensitive liability culture. Providers were suddenly facing audits and the threat of losing their licenses, creating an atmosphere of institutional fear. Hospitals used to be environments centered on healing and observation, but under the weight of these new legal threats, the architecture of care shifted. Clinics transitioned into environments built on suspicion and risk management.
The pressure warped how providers perceive the people sitting in the exam room. A patient begging for relief from a symptom is often no longer seen as a person in pain. They are viewed as a potential legal liability that needs to be contained and documented. Doctors find themselves in a position similar to the 1971 guards. They are responding to institutional pressures that prioritize the protection of the clinic over the person in the room, creating an environment where treating the patient as untrustworthy is the safest professional choice. The primary tool for this de-individualization is the medical chart. It takes a human life, complete with biological diseases and trauma histories, and flattens it into bureaucratic data. This flowchart illustrates how the system operates before a doctor even enters the room. Automated insurance algorithms scan your file, tally up the different specialists you see and the medications you take, and instantly generate a warning flag. Complex patients are reduced to generic polypharmacy risks entirely by code. Once that flag is planted, the relationship is compromised. Providers open the chart, see the warning, and view the patient's questions through a lens of suspicion. They stop gathering data and start looking for evidence to support the flag. This creates an epistemic trap. It is an unwinnable catch-22, where a patient's own intelligence and logical self-advocacy are used as proof of a mental health condition. If a patient memorizes the exact names, half-lives, and dosages of their medications to stay safe, the system doesn't see a responsible adult. It documents them as a manipulative drug seeker who knows the system too well.
But if the patient cries out in physical agony, the outcome is the same. The medical team labels their distress as a personality disorder, or writes off the pain as malingering, an intentional performance to get attention. The chart guarantees the patient cannot win. Every logical attempt to find relief is recorded as a psychiatric symptom. The system's own failure to provide care causes the patient's distress, and then uses that distress to justify denying them further treatment. To manage these patients, providers adopt a defensive posture. They are focused on mitigating the institutional risks laid out in the medical chart, rather than investigating the symptoms sitting in front of them. The logic of medical liability dictates their actions. If a doctor takes a risk to treat a complex symptom, they are legally responsible for the outcome. But if they label the symptom as a behavioral issue, they avoid the risk of intervening at all. This leads to a technique often called gray rocking or non-reaction. When faced with a patient's physical complaints, providers misuse psychiatric concepts like distress tolerance. Instead of treating the biological problem, they instruct the patient to endure it. This approach has dangerous consequences. Physical emergencies like a 104-degree fever from sepsis, a broken toe, or complete neurological sleep failure are documented as emotional dysregulation. The patient is asked to use coping skills while their body is in a state of medical crisis. The medical ethic of do no harm becomes an administrative shield. By reframing a medical emergency as a behavior to be managed, the institution avoids the legal risk of providing necessary treatment. Look at this network map to see how a poison pill chart functions. When a label like factitious disorder or malingering is added to a file, it migrates through modern electronic health record systems automatically. Because these records are shared, new specialists read the false narrative before the patient even walks through the door. Viewing the patient through this lens, doctors refuse to treat them, citing a lack of a therapeutic relationship. The patient becomes untouchable within the medical community. They are bounced from psychiatry to sleep medicine and back again, endlessly referred out and unable to access care for their primary illness. The contaminated file creates a closed loop. Because no new doctor will override a previous claim of malingering, the patient is removed from the healthcare system by default, regardless of their physical condition. Addressing this institutional discrimination requires more than better bedside manner. It requires a legal framework that treats these diagnostic shortcuts as a violation of civil rights rather than a clinical disagreement. There is an urgent need to enforce the Americans with Disabilities Act to stop this abuse.
The medical system should not be allowed to pathologize a patient's intelligence and self-advocacy, using stereotypes about disability to deny them access to healthcare. Patients must be granted the legal right to challenge, audit, and remove false punitive psychiatric labels from their electronic records. The power to define a person's medical reality cannot belong solely to the institution. Until the law forces a change, chronic pain patients will remain trapped in an experiment they never consented to. They are operating in a system where attempting to prove they are sick is treated as a behavioral choice, and the people meant to heal them are acting as the guards.